All right, good evening, everyone. We're going to run through this lecture this evening on congenital abnormalities. And just to let us know, okay, so we're going to look at our learning outcomes. We want to learn about the causes and risk factors of congenital abnormalities in children. We want to learn about the common congenital abnormalities and their likely management. And we will proceed to look at some prevention strategies of congenital abnormalities. All right, so congenital abnormalities, also known as birth defects or congenital disorders or congenital malformations. So the WHO referred to congenital abnormalities as either as a birth defect, a congenital disorder, or congenital malformations. Generally speaking, congenital abnormalities could be structural or functional. And functional congenital abnormalities include metabolic disorders that are present at birth. Congenital abnormalities is common. It affects about 1 in 33 infants. So, to be stricter with our definitions, congenital anomaly or abnormal chemical, structural, and functional disorders that are present at birth. While congenital malformation strictly refers to structural defects that are present at birth. So when we talk about congenital abnormality, we're talking about everything, both structural, both functional biochemical disorders that are present at birth. So what are some of the causes, common causes and risk factors of the congenital abnormalities? I'm sure you are used to me now. We just put the word genetics. All right, genetics, where G refers to genetics itself. E is environmental factors such as exposure to pesticides, alcohol abuse, and drug use. And refers to nutritional factors such as deficiency of folate and iron. Economical, it can be as a result of poverty, low social status, and it actually results from the touch complex, which refers to infection with toxoplasmosis, rubella, cytomegalovirus, Haemophilus influenza. It actually also results from HIV infections. There could be some social factors such as social class. Some congenital abnormalities are common in certain social class than the other, or factors like radiation, exposure to radiation, occupational hazards, and all that, which also has to do with environmental. So generally speaking, these are some of the common causes or risk factors for development of congenital abnormalities among the newborn. Risk factors also include advanced maternal age. The older a mother is before giving birth, the higher the risk of giving birth to children with congenital abnormalities. Patients with Down syndrome, consanguinity, this common sensory, all right, some disease, some congenital abnormalities are common in some ancestral lineage. Maternal malnutrition, iodine deficiency, all this can lead to mental retardation in the newborn, and folic acid deficiency can lead to central nervous system defects, as we're going to see. So these are some of the common risk factors. Etiology, quite a number of these congenital abnormalities are of unknown origin. More than half of these abnormalities have no known etiology. Multifactorial factors come into play. What it means is that not just one or two, and that represents the second group of congenital abnormalities, representing about 1/4 the incidence or the etiology. Chromosomal abnormalities, mutations, and environmental factors account for almost the same percentage, a little less than 10% each of them. So the common etiology is unknown. You know, when we're talking about congenital malformation, more than 50 to 60% of these cases have unknown etiology. So how do you make a diagnosis? Diagnosis of congenital abnormalities can be made prenatally or postnatally. And now with advancement in technology, it's important to make a prenatal diagnosis of many of the congenital abnormalities. So amniocentesis at 14 to 16 weeks of gestation can give us an insight into chromosomal abnormalities and inborn errors of metabolism. Chronic viral sampling can be used for cytogenic study, and alpha-fetoprotein and gonadotropin assay can actually be used to make a diagnosis of neural tube defect or trisomy. Amnography, soft tissue abnormalities, spectroscope can be used prenatally to look at fetal well-being, and antenatal screening, actually oftentimes ignored, can actually give an insight into maternal disease, all right, that could impact on the newborn in terms of developmental malformation. After the child is born, we can do biochemical assay. Cytogenic study can be used for early detection of many congenital abnormalities. Blood tests may be ordered for as appropriate. We can do hormonal assay and all that. So these are different ways of diagnosing congenital anomalies in children. So we're going to, like I mentioned, we're going to run over, it's an overview of the common congenital abnormalities that we see. We're not going into too much details into the pathophysiology and all that. As an institute, it's important for us to have a good grasp of some of these common congenital abnormalities. So the first one we're looking at is hydrocephalus. All right, many of us must have anesthetized one or two patients with hydrocephalus for either BP shunt or whatever it is. So hydrocephalus refers to increased cerebrospinal fluid due to either increased production, all right, increased production or decreased drainage. Usually, hydrocephalus results from decreased drainage. Don't forget that CSF is produced by the ventricles. All right, so hydrocephalus can be divided into non-communicating or communicating. Non-communicating hydrocephalus results from block, okay, of CSF flow between the lateral ventricles and the fourth ventricle. While communicating hydrocephalus results from blockage distal to the fourth ventricle outlet. Most of the times at the basal systems. So etiology, hydrocephalus can result from congenital issues like Dandy-Walker syndrome and Arnold-Chiari syndrome. It can also result from meningitis, head injury, and subarachnoid hemorrhage, where this can lead to blockage of CSF free flow. More often than not, hydrocephalus, if you remember our Mulcahy's doctrine, we know that hydrocephalus may be associated with raised intracranial pressure, and it's a lot of times this requires acute drainage, or this may actually result in a chronic form with small or slow ventricular enlargement. One of the things you will see with children with hydrocephalus is that they have increased head circumference with bulging fontanelles. Because of the space taken up by the CSF, you can have cerebral or cerebellar atrophy. And a lot of times in treatment, the surgical intervention to remove obstruction and to insert the shunt right from the lateral ventricles, either to the peritoneum or to the atrium. So this is what we know as our deep pitch of ventricular peritoneal drainage. So this is in nutshell hydrocephalus. The second we're looking at, the second common congenital abnormalities is spinal bifida. All right, this refers to failure of the vertebral column to close during development, and this leads to protrusions of the membranes surrounding the brain and the spinal cord. So spinal bifida is a type of neural tube defect. The severity of spinal bifida depends on the size and location of the defect. All right. It also depends on whether the spinal cord or part of the spinal cord or nerves are affected. There are different types of spinal bifida. We have the spinal bifida occulta, the meningocy, the myelomeningocy. All right, the spinal bifida is the minded type, which results from a small gap in the spine without any opening or sac protruding at the back. Many times, prenatal tests with alpha-fetoprotein will suggest the presence of spinal bifida occulta when you have very high levels of alpha-fetoprotein. Ultrasonography can be done. Amniocentesis, like I mentioned, are 14 to 16 weeks. After birth, a hairy patch of skin or a dimple, treatment is usually surgery. All right, so okay. So I'll come back to that. Okay, let's go to this slide. You can see on the left, you see the different missions that can occur. The picture B, there is, all right, an abnormality, an opening, but there's a failure or closure of the vertebral column here, but there's no protrusion of the meninges or the nerves. So this is the Mendes form. Meningocy is when you have a part of the spinal cord herniating through the defect, but it does not have any nerve or neural tissues. All right. Meningomyelinosis is the severest form, in where you see not only the meninges protruding through the defect, but you see some neural tissues proceeding with it. This one has a severe cause of event. So, like I said, the myelomeningosis is also known as open spinal bifida, and is the most severe type. The membranes and the spinal nerves push through the opening at birth, which forms a sac on the back of the child, typically exposing tissues and nerves with a lot of residual, neurological fallout. Now, this makes the child to be prone to life-threatening infections like meningitis, and may also cause paralysis, bladder and bowel dysfunction because of the protrusion of those nerves into the defect. Meningocy is a sac that protrudes from the spinal column, which contains spinal fluid but not neural tissue. All right, it may be covered with skin or with meninges. Don't forget that the risk factors include deficiency of folic acid, and that's why a lot of times remember that we give folic acid to pregnant women during antenatal period. Family history of neural tube defect. All right, patients that have fever, mothers fever, anticonvulsants such as sodium valproate, and patients with mothers with diabetic mellitus and obese patients. These are some of the risk factors for development of spinal bifida. If you look at the pictures again, you can see the difference between meningocy and myelomeningocy. So there are a lot of complications of spinal bifida, results from, you can have orthopedic problems such as scoliosis, all right, because of the nature of the column, vertebral column. You can have postural abnormalities such as walking and mobility problems. And there could be obstructions to CSF flow, which can lead to hydrocephalus. The meninges are exposed, so they can have meningitis. We can have KRA malformation type 2. There's what we call theta spinal cord, in which is as if the spinal cord is under tension. We can have skin problems, latex allergy from repeated surgical procedures, and sleep disturbances because this child may not be able to lie on his or her back. All right, so we move on to the congenital heart problems, heart defects. All right, they are typically categorized into two, cyanotic and acyanotic heart defects. All right, the cyanotic heart defect usually as a result right to left shunt, deoxygenated blood entering the left side of the heart, causing cyanosis. And we have different types of right to left shunt leading to cyanotic heart disease, the tetralogy of Fowler, the transposition of great arteries, the transcorpus valve lesions with Epstein's anomaly, pulmonary atresia and septal defect. Or you can have a patient with single atrium and or ventricle. So this will lead to right to left shunt with cyanosis developing. Patients with cyanotic heart disease will have feeding problems, they will have failure to thrive, they will have often are exposed or predisposed to congenital heart failure. Obviously, they are cyanotic and they have difficulty with breathing. You can see or hear valvular murmurs as a result of valvular problems. The acyanotic heart defects due to, it will be due to left to right shunt, but in the presence of pulmonary hypertension, this may potentially be cyanotic, especially in what we know as the Semengers syndrome. Conditions that lead to left to right shunt include ventricular septal defect, ASD, and PDA. Sometimes you can have obstructive lesions where there are no shunts, like pulmonary stenosis, aortic stenosis, or coarctation of the aorta. In the GI, we can have common congenital abnormalities such as encephalus or gastrochesis, okay? All right, encephalus or omphalocele, all right? This refers to, I'm going to come to this one, this refers to a midline defect, all right, related to the umbilicus, which is due to failure of the bowel and other abdominal organs to return to the abdominal cavity during fetal development. We know that most of bowel and other intra-abdominal organs should return into the abdominal cavity during fetal development. But when this fails, these intra-abdominal organs remain outside of the abdominal cavity. And that's where you have omphalocele or encephalus, all right? And incidence is about 1 in 5,000 to 10,000 live births. Gastrochesis is more severe, in which you have abdominal wall defect, but this is not associated with any midline umbilicus, but it causes herniation of its abdominal contents without any sac covering it. It's rarer, incidence about 1 in 30,000 live births. But GI common congenital abnormalities are actually associated with prematurity. Children that are born premature is also common in other patients with other congenital abnormalities, such as heart defects. Challenges with omphalocele or gastrochesis is there's damage to the supposedly intra-abdominal organs, and because of that, we have fluid and electrolyte imbalance because of lack of absorption, heat loss because the intra-abdominal organs is exposed, so it leads to decrease in core temperature, obviously infection. So these organs are normally protected by the abdominal cavity. Treatment is that once you see a neonate born with omphalocele or gastrocheeses, you want to try to cover the bowel that is exposed with a dry towel or a plastic bag, and you prepare for surgical closure. Sometimes the surgery may be staged, all right, because trying to return all the contents of the content that are outside, the abdominal content outside into the cavity may be difficult, and you can have difficulty with ventilation. So some surgeons stage it, but it also depends on the skin that is overlying the abdomen. Don't forget that post-operatively, this patient may require intermittent positive pressure ventilation because of the difficulty with ventilation, especially when these organs are returned into the abdomen. All right, so these are likely questions. What are the differences between gastrocheeses and omphalocele or esophagus? Or just remember that in gastrocheeses, the abdominal content, especially the bowel, are outside of the abdomen through a hole in the abdomen. While this one, the intestines, the liver, other organs remain outside of the abdomen in a sac. So omphalocele has a covering sac, while gastrocheeses does not have a covering sac. That makes gastrocheeses more severe and more prone to complications. All right, so these are a lot of times I like asking this question. It's not likely that you will miss it in the exam. So just look at it. Gastrocheeses, the content is usually on the right side, while in gastrocheeses, the contents are not covered by any membrane or any sac. All right, why it is not like that in omphalocele. Remember that there's no umbilical cord in gastrocheeses, but in omphalocele, you may see the umbilical cord is started in other area of the inside. All right, this happens during embryology and this happens during the fetal development. All right, content, a lot of 100% intestine. All right, then you can have colon, bladder, and gonads occasionally. But here, in most cases, it contains not only the intestine, it has liver, all right, in it. Spleen and colon bladder may be present occasionally. And luckily, gastrocheeses, although it's more severe, is rarely associated with other congenital abnormalities, about 15% association. While omphalocele, which is commoner, is usually frequently associated with other congenital abnormalities like heart. All right, sometimes you may even have what we know as a Vater syndrome. So these are things you must look out for during your preoperative assessment for a child being scheduled for omphalocele surgery. All right, look for other congenital abnormalities. All right, other GI problem is the Hirschsprung's disease. All right, this is the most common cause of lower intestinal obstruction in neonates. All right, when a child is born not passing through vomiting, distended abdomen, you want to rule out Hirschsprung disease, and it's due to the difference in the ganglions along the colon. So we have what we know as aganglionic megacolon. So there is no normal peristalsis in the bowel. So there's a failure of migration of the neural crest, leading to abnormal innervation of the bowel. The defect begins in the internal anal sphincter and extends proximally for a variable length of the gulf. All right, the length of gulf that is affected can have prognostic implication. So most of the time it's congenital, all right, which is the commonest type. Sometimes it may be acquired, which may be vascular or non vascular in origin. So clinical features of Hirschsprung disease includes failure to pass meconium stool in the first 24 hours of life. The patient will have features of intestinal obstruction with vomiting and abdominal distension, pain, wriggling and pain. All right, a lot of times this patient have recurrent enterocolitis in the first 3 months of life. The diagnosis is rectal biopsy with absent ganglionic cells along the bowel. So when there are no ganglionic cells, it gives out the diagnosis of apron disease. All right, so this is apron disease. These ganglion cells all over. All right, the descending column. Well, here there are fewer or absent, especially if you see here, there are no ganglionic cells here, and as a result, there's accumulation of bowel content, proximal to this region. So you have what we call aganglionic megacolon. You can see it's distended. There is no peristalsis because of loss of innervations of this part of the bowel. All right, so other congenital abnormality we look at this evening is the tracheoesophageal fistula, and we have different types of tracheoesophageal fistula from A to E. Now, this a lot of time in association with esophageal atresia, which occurs in about 1 in 3,000 births, with tracheoesophageal fistula in 25% of cases. When there's esophageal atresia, all right, you most likely will have in 1/4 of cases tracheoesophageal fistula. All right, it also may be associated with what we know as the Vater syndrome. What are the clinical features of TOF? The patient chokes on feed, coughing, and cyanosis. And this is because, contents, gastric contents, or, esophageal contents get deposited in the airway, and it obstructs the airway, so the patient chokes on feeding, all right, and coughing, trying to get it out. And because of the choking, there is cyanosis. The patient becomes cyanosis because the blood is not well oxygenated, and you have stomach distension. So it's usually suspected initially when you have difficulty or unable to pass an NG tube into the stomach. All right, you want to pass an NG tube and it's not going through the stomach, and you can also confirm it when you see your NG tube coiling, into a blind upper esophageal pouch. So this gives it gives an indication of tracheoesophageal fistula, and the repair is usually a surgical repair. It could be due to thoracotomy or whatever procedure the surgeon desires. So if you look at the commonest part, the commonest tracheoesophageal fistula is C, in which there's esophageal atresia, but there is a fistula joining from the lower part of the esophagus to the trachea. And B is when there's a fistula formation between the upper esophagus and the trachea. All right. In about 7.8%, there is no fistula at all. All right. There's discontinuation of the esophagus. All right. In E, there's a continuation of the esophagus, but there's a fistula, okay, with the trachea. But the commonest is when there's a fistula formation between the lower esophagus and the trachea. Choanal atresia is a common ENT problems. This results from failure of the nasal cavity to connect or communicate with the nasopharynx during development. So there's a failure of connection or communication between the nasal cavity and the nasopharynx. It's a very rare occurrence with incidence of 1 in 5,000 to 8,000, and it's common among female children between 2 to 1. It's associated with coloboma infections, heart disease, atresia of the choanals, both of them. It's also common with retardation, general hypoplasia, and ear deformities or deafness because of the connection with the eustachian tubes. There are different types of choanal atresia. We can have unilateral, which rarely causes respiratory distress. You can have bilateral choanal atresia with complete nasal obstruction, with immediate respiratory distress, with aphasia, cyclic respiratory obstruction, and this child opens his mouth to breathe. Okay. So that diagnosis physical is personal feeding tube. All right. You can have other means of doing acoustic rhinometry. CT scan usually confirmatory when you see that there's a failure, okay, of the nasal cavity joining. All right. You can actually put an oropharyngeal airway, or you tube this patient for management. All right. So this is okay. So this is cleft lip. Okay. So cleft lip is another congenital abnormality. I will come back to this diagram or these pictures later on. So let's go. Cleft lip is a bad defect that is characterized by either unilateral or bilateral opening in the upper lip between the mouth and the nose, while cleft palate is characterized by an opening in the roof of the mouth. All right, this is caused by lack of tissue development. All right, you can see here. All right, this is a unilateral incomplete, both opening here, like complete. This one is complete, and you can see bilateral cleft lips with cleft palate. This opens into the roof of the mouth. So what are the problems as we go with cleft lip and palate? Mnemonics feeds. All right. So usually they have feeding problems, what we know as the glue ear. They have aesthetic problems and emotional problems. May arise because of the obvious different problems, and many of them can have tooth decay. They will have problems with speech because of the defect. Now, so if you have a child coming for cleft lip repair, you need to consider fluid and feeding imbalance, all right, because the brain has feeding problems, and this will lead to electrolyte imbalance. You want to ensure that you want to take your electrolytes. This is not the time to gloss over electrolyte, check. Exposure, this patient a lot of times are exposed to repeated anesthetics and surgical repair. Don't forget that you may have difficulty airway or difficult intubation. Don't forget that this patient may have problems with swallowing, so the risk of aspiration pneumonitis is always there. And don't forget also, you must always look out for other associated congenital abnormalities. All right, so we have the Miller's rule of 10 for correction of cleft lip or cleft palate. All right, so before surgical correction of cleft lip or cleft palate, remember that the patient must be up to 10 weeks of age, weight of 10 pounds, and hemoglobin concentration of 10 grams per day. So this was the Miller's rule of 10, and there have been some controversies on people are about to go around it, but this is the standard that we started with. So the Miller's rule of 10, the child must be 10 weeks, at least minimum of 10 weeks of age before presenting for surgery. He must at least have a weight of 10 pounds and hemoglobin concentration of 10 grams per day. All right, so these are some of my references. Okay.